This video will demonstrate the extended transotic anterolateral infralabyrinthine transjugular approach for resection of a glomus jugulare tumor. The patient was in her early 70s. She presented with 2 years of right shoulder shrug weakness, progressive hoarseness caused by vocal cord paralysis, and right ear tinnitus. On exam, she had right upper extremity proximal weakness. Here are her MR images, which show a tumor filling the jugular bulb and extending down into the cranial portion of the internal jugular vein, seen here on the coronal and sagittal views. This is a Fish type D tumor. The CT angiogram shows the anatomy of the blood supply to this tumor, with the yellow arrows marking the ascending pharyngeal artery, which is quite dilated. Note its intimate relationship with the internal carotid artery as well as the internal jugular vein. Here is the patient position, skin incision, and craniotomy for this approach. Surgical strategy consisted of the combined retroauricular and high cervical skin incision, retro and infralabyrinthine mastoidectomy, skeletonization of the semicircular canals, fallopian canal, sigmoid sinus, and jugular bulb, high cervical exposure with removal of the mastoid tip, ligation of the sigmoid sinus above the tumor, ligation of the internal jugular vein below the tumor, opening of the sigmoid jugular venous sheath, piecemeal tumor removal, and importantly, leaving the medial jugular venous wall intact to protect lower cranial nerves. Here's an overview of the surgical exposure. The top of the head is to the left, the feet are to the right, and the angle of the mandible is at the top of the screen. Here the neck dissection is being completed. You can see the internal and external carotid arteries there. Here the mastoid tip is being dissected free from its muscular attachments. It has been drilled out cranially and is freed inferiorly for removal. Additional bone here is cleaned away from the mastoid tip, and this allows the sternocleidomastoid muscle and the deep cervical muscles to peel back and widely expose the internal jugular vein. Here now you can see the internal jugular vein along its course to the skull base. It's being lifted by my sucker. Now the drilling of the cranial portion is completed. My neuro-otology colleague did the transotic exposure, and here I'm widening the exposure of the distal sigmoid sinus and jugular bulb. This bone removal is important because it brings the jugular bulb into full view. Now the distal sigmoid sinus is being suture ligated here and divided. Notice how the silk sutures have been passed underneath the sinus from 2 dural incisions on either side. In similar fashion, the internal jugular vein is doubly suture ligated. Now the transotic infralabyrinthine drilling is extended. This is to remove the remaining bone overlying the jugular bulb. Now the tumor is reached. The bone here is whittled away or eaten away by the tumor. The tumor was quite vascular, and the tumor had not been embolized preoperatively, and therefore a temporary clip was placed on the external carotid artery and the ascending pharyngeal artery. Even with that temporary clip occlusion, the tumor itself remained highly vascular. Here I'm defining the planes between the tumor and the surrounding petrous bone. The tumor could then be removed piecemeal. A round knife is used to pull the tumor into the central portion of this operative corridor, and it can then be removed piecemeal. You can see how vascularized and bloody this tumor was without this preoperative embolization. Here's another nice view of the vascularity of this tumor. Once the tumor had been cored out centrally, you can see that the bleeding is nicely controlled now. I've removed tumor all the way forward to the dura at the skull base ventrally. You can see here I'm chasing tumor inferiorly. Here you'll have a view into the internal jugular vein, and you can appreciate how there is very little tumor within the lumen of the internal jugular vein. The tumor had grown medially to the vein and up into the petrous bone. Now the temporary clip can be removed from the external carotid artery. Hemostasis is achieved within the resection cavity, and this is our final overview. This infratemporal fossa approach is one of the most complicated anatomical regions in the skull base, and this illustration here shows why. You can see the confluence of the venous anatomy with the transverse sigmoid jugular bulb and internal jugular vein. You can see the course of vital cranial nerves like the facial nerve coursing through its fallopian canal. You can also see the relationship of this exposure to the semicircular canals. The tumor resides medial to the semicircular canals in this space around the jugular bulb, as shown on the illustration to the right. Here are some cadaveric dissections highlighting some of the soft tissue dissection that is needed to bring this region into exposure. You can see how the mastoid tip needs to be removed, the digastric muscle needs to be divided, and the internal jugular vein needs to be traced from the neck all the way through the jugular bulb and up to the sigmoid sinus. The illustration in the lower right shows the course of the venous anatomy after the venous sheath has been opened to expose the internal luminal side of the jugular bulb. It's important to preserve the medial wall of the jugular bulb because this protects the nerves as they exit through the pars nervosa of the jugular foramen. The patient tolerated the procedure well. Her shoulder weakness improved immediately after surgery. She was discharged home on postoperative day 5. Here are her postoperative MR images showing a good resection of the tumor. The vast majority of tumor was successfully removed with a small remnant on its superior aspect that extended up to the region of the internal auditory canal. The bottom left image shows the bony removal that was needed to access this region. In conclusion, glomus jugulare tumors are rare, slow-growing neuroendocrine neoplasms, or paragangliomas, arising from the paraganglia in the jugular bulb and presenting between 40 and 70 years of age. About 80% of cases are sporadic, and the remaining 20% are familial and associated with hereditary paraganglioma pheochromocytoma syndromes. Large tumors are highly vascular and warrant preoperative embolization. Tumors cause dysfunction of the lower cranial nerves and sometimes brainstem compression, in which case surgical excision is warranted. Thank you.